Yeah, I think we're ready. Again, thank you, our speakers. Thank you, our attendees, for joining us tonight in this SSBMT webinar series. Today, actually, our webinar is sponsored by Novartis. Thank you, Novartis, for sponsoring this event. So today, our webinar will be about sickle cell disease. And we have two elite speakers. The first speaker is Dr. Or Professor David Rees. Professor Rees, he's a professor of pediatric sickle cell disease at King's College Hospital, King's College London. Dr. Rees, he has extensive research in sickle cell disease and other red cell disorders, and he is the director of the National Acute Porphyria Service as well at King's College Hospital, and the medical advisor to Sickle Cell Society in the UK. So Dr. Rees will be talking about tonight for 20 minutes, right, Dr. Rees?
Yes, 20 minutes.
Sickle cell disease, complications, manifestation, and public health. And just before you start, Dr. Rees, I'll just remind our attendees that there is a Q&A icon there, and we'll please post your questions at the end, not now. So we'll attend to these questions at the end of the two talks. And if you could address your question to which speaker at the end, and we will have a quick survey question at the end of this webinar, which will extend for 1 hour. So the floor is yours, Dr. Rees. Please go ahead.
So I click. Is that on now? People can see that?
Yes.
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 Okay. Well, as I'd like to thank the organisers for inviting me to talk at this meeting. I'm not quite sure how it works as a webinar, but I will go through my slides. How do I get the next one is the question. This, yeah. This is a very shortened account of the pathophysiology in sickle cell disease, which I think you're going to hear more about later, showing that the disease starts in the red cell, which is damaged by the polymerization and damages blood vessels, and then there's a whole cascade of manifestations, resulting in organ and blood vessel damage, resulting in a number of clinical complications. I won't really say any more about that. The other important point I'd start off with is that there are obviously sickle cell disease is a number of different things. There are about 15 different genotypes which can cause sickle cell disease. Obviously, sickle cell anemia, SS, is the one that is most common across the world. But in African origin populations, SC makes up the majority of the other cases. In the Middle East, in general, S-beta thal SC is rare, and S-beta thal makes up about 25, 30, 40% of cases, whereas SS makes up the remainder. They're all kind of distinct, but most of what we know and most of what we talk about and most of what I talk about really applies definitely to SS. It's always inferred that it might also apply to S-beta thalassemia, but the number of studies on S-beta thalassemia and SC is actually quite sparse, and there are some important differences between the two conditions. Just talking first of all in terms of the burden, talking about the life expectancy. Really, this is a figure that is shown quite often in many talks, really, but not based on a whole lot of actual data. But in 1910 was when the sickle mutation was first described, and in those days it was thought to be essentially a disease of childhood in the sense that no one survived to adulthood, and based on fairly rough approximations, that situation continued until the 1970s, when in the States and probably in Europe and some other countries, then the life expectancy started to improve. Why it started to improve isn't entirely clear. It wasn't due to treatment. Probably one of the important things was in the States, the National Sickle Cell Anemia Control Act, which didn't really change anything other than saying that creating a series of sickle cell centres and trying to identify sickle cell specialists to recognise that this was an actual condition that required specialist care. And that is probably the main thing. And that sort of approach, just the, having people who are interested in the condition is one of the things that has made the biggest improvement. The screening kind of came in and along with that, so that children were identified early on after birth. And in some countries, the impossibility of having antenatal screening to avoid the birth of children with sickle cell disease in various ways has also led to some improvements. Penicillin was developed in the 1980s, showing in studies in USA, which have never really been repeated anywhere else, but are assumed to apply certainly in Europe, and increasingly seem likely to apply across the world, showing that penicillin reduced the morbidity and mortality related to invasive pneumococcal disease. Hydroxyurea was developed in the 90s, and then in the 90s as well, the STOP study trying to prevent stroke was developed. Along some of these things obviously developed more recently. There are some other drugs starting to emerge, but there haven't been any great advances overall since then. Obviously, bone marrow transplantation has gradually developed since the 90s in sickle cell disease, but it's still in most countries, is still a fairly important, but only really applies to a minority of patients. So survival, as I've said, it depends a bit where you live. The survival, it's in high-income countries now. Then there are some fairly good studies in London. The paediatric survival seems to be about 99%, in the sense that most children lead to nearly all children reach the age of 16, and those figures are pretty much reproduced in other high-income countries in the 90s and more recently. There aren't that many studies there are very few studies from the Middle East giving an idea of how many, what pediatric survival is like. There aren't that many studies in Africa, although a study in Tanzania providing good quality care in Dar es Salaam showed that even with the optimal care in that country, the majority of children died before the age of 16. And then overall survival is definitely decreased in all countries. Again, it's a difficult thing to estimate, and there are various studies, but the studies that have been done in the States, the UK, and Jamaica suggest that survival is shortened by maybe 20 to 30 years compared to the normal survival for adults in those countries. It's obviously no longer a pediatric disease, and in terms of serious interventions like bone marrow transplant, where there's a risk of significant injury or death related to the procedure, then it becomes a complicated equation when the median life expectancy may be over 60, and you're doing this in a child. But obviously that's beyond the scope of my talk about the burden of disease. One of the consequences of increasing survival in high-income countries, and I think probably the Middle East, is that there's a changing population, that now there are quite a big population of patients living over the age of 50, and they come with a significant burden of disease, really, that is not the typical pattern of sickle cell disease, related primarily to organ damage and organ failure. So complications like renal failure, pulmonary hypertension, cardiovascular disease, cerebrovascular disease, arthropathy, not so much acute pain, but chronic joint damage, diabetes mellitus is increasingly common, and venous thromboembolic disease is increasingly recognized. And cancer does seem to be increased in people with sickle cell disease to some extent, although the overall, it is a fairly small risk factor, but that pattern is starting to emerge. This is the version of the graph that crops up in most talks, showing that the top figure shows the distribution of sickle cell disease across the world, really showing it's predominantly a disease in Africa and the Middle East and India. It occurs through migration largely in other parts of the world. The bottom map shows the distribution of malaria, which is one of the strands of evidence for the well-known effect that sickle cell is so common, because being a carrier, in fact, protects you against malaria to a remarkably high extent, and in malarious countries also provides quite a lot of other advantages in terms of protection against other infections. So the overall selective advantage of being a sickle carrier in malarious areas is very high. In non-malarious areas, it's probably detrimental, and there's quite a lot of evidence emerging now about sickle carriers having health problems, but overall that is outweighed by the benefits in the large parts of the world where malaria is still a problem. And this is the so-called cartogram, where the area of a country is proportionate to the number of newborns in that country, showing that it's dominated. Africa dominates the picture, with the Middle East and India also showing up, but Europe and the States really having although a lot of the noise comes from those countries, the burden of the disease is really quite small relative to many parts of the world. These are estimates. These are not actual figures. No one knows how many people in the world have sickle cell disease, but there's really no accurate estimates, but it's more than 1 million is what most people would say. These are estimates based on the number of births in 2010. Their numbers are very precise, although, as I say, they're not actually measured. But again, the vast majority of the births occur in Africa, in the Americas, and then the Eastern Mediterranean, including the Middle East, with small numbers in Europe relatively, and very few in Australasia. This is a selection of countries. Not obviously, there are calculated figures for all these countries, but again, the three main countries are Nigeria, India, and the Democratic Republic of Congo dominate enormously. Most of the other high countries in the thousands are in Africa. In the Middle East, there are significant numbers of patients. In the UK, for example, then the number of births are about 300 a year, which makes it, in fact, the commonest severe inherited disorder in the UK. It's more common than cystic fibrosis and haemophilia, but it's obviously the numbers are much smaller than in most of the Middle East, in Saudi, in Iran and Iraq, where, although it's not very, very common, it certainly produces a significant number of children with significant burden of disease. The other issue in Europe more recently has been the numbers have increased in Europe quite a lot in the last 20 or 30 years, and particularly in the last 5 years. Countries which previously had a small number of patients are now having quite a lot of patients, and those countries such as Denmark and Germany and Northern Europe, and to some extent Italy and Greece. Suddenly Europe's become more aware of sickle cell disease, because countries, in particular Germany, which didn't have many patients previously, are now seeing quite a lot of patients due to recent migration from some troubled countries in the Middle East and from African countries arriving through Southern Europe and tending to migrate to Northern Europe, including the UK. The numbers in the UK have been fairly stable. There are about 15,000 patients in the UK with sickle cell disease. But in Germany, say, the numbers have gone from a handful, from 50 or 100 to 3,000 in a few years, which is, again, not a huge number, but they require quite a lot of medical care and attention, so services are having to be developed. And across Europe now, there are more proposals for widespread screening in Europe, for European-based guidelines and a European registry, and the idea that patients might have a passport which holds their records. So, because patients with sickle cell disease are traditionally quite mobile, and particularly at the moment where they tend to, as they travel across Europe and get health problems in each of the countries, and it's difficult to maintain an accurate record of that. The other big burden of sickle cell disease tends to be social, there are some studies on it, but it's not very well studied. But in general, as a general rule, health outcomes in all countries are worse in poverty in all populations, and sickle cell disease tends to be, I think, pretty much in all countries, most prevalent in it's most prevalent in low-income countries, and it also tends to be a disease of urban and poor populations in many countries. And the two possibly go together, but they add to the social burden of it. As you'd expect, there are studies suggesting that if you have sickle cell disease, you earn more money and pay less tax. In the USA, then there are more single-parent families, there are more women who are heads of families, but in fact, high school graduation is just as common. So again, there is definitely, as I'm sure anyone who works with sickle cell disease knows, there is a big social burden to it, but it's not very well studied and not very well quantitated. So moving on to the complications, really, obviously in a short talk, you can't obviously there's a huge sickle cell, although it only involves red cells directly. Almost every organ and cell in the body is affected in one way or another. So I'll just run through broad categories and then talk about one or two complications. Broadly, there are acute complications, and these are a lot of them are related to vaso-occlusion, where you block blood vessels, and these include acute pain, acute chest syndrome, splenic sequestration causing acute anemia, stroke, and priapism. And I'll talk about the pain, chest syndrome, and stroke. Infective complications are undoubtedly important, and sepsis, doing it particularly from invasive pneumococcal disease, is one of the commonest causes of death. It's still in the UK, in fact, although death is very rare in children, but in low-income countries, or in countries which don't have a very highly developed healthcare service, and that's one of the major causes of death. Parvovirus, osteomyelitis, and malaria is very important worldwide. Then there are other things, many of which are iatrogenic, really, cholecystitis, but problems relating from how sickle cell disease is treated cause a lot of burden of disease, partly due to difficulties with opiate analgesia and side effects of those, including death through oversedation and requirement to take opiate analgesia long term, resulting in frequent hospital admissions and all sorts of kind of complications. Sudden death is a feature of sickle cell disease for many reasons, and then there are hemolytic transfusion reactions, which are a problem in countries where regular blood transfusion is used and available. Chronic complications are mostly related to damage to blood vessels, vascular endothelial dysfunction, including cerebrovascular disease, pulmonary hypertension, and venous thromboembolic disease, or they're related to progressive end organ damage, really, such as causing avascular necrosis, chronic kidney disease, chronic lung disease, sickle liver disease, which involves lots of things, and leg ulcers. Chronic pain is a big feature of adults with sickle cell disease, which is very difficult to manage, and again results in sometimes frequent admissions to hospital and high doses of long-term opiate use. Other problems include the socio-economic disadvantages I've mentioned, cognitive and psychological problems related to having a chronic illness, and also direct effects on the brain, long-term use of analgesics, and then transfusional iron overload. Talking briefly about acute pain, that's the condition that stands out for most people, and that this how most patients turn up to hospital. Dactylitis occurs particularly is a pediatric feature, and it's often the first presenting of feature of sickle cell disease in the absence of a screening program. Mostly it's young children under 2 years of age. It's generally not harmful. People used to admit everyone to hospital with it, but now we encourage people to be managed at home with simple analgesia, and only when the pain is severe do people come into hospital. In general, in children particularly, we try to avoid intravenous or parenteral analgesia unless it's not possible to control it with oral analgesia. And there is some randomized controlled trial evidence to support that approach. This is a typical picture of well, not entirely typical, but the dactylitis affecting one hand where the hand is very swollen. Many children, if you have one episode, you tend to have two. In general, it's a benign condition and imaging is not necessary. But obviously, it's important to give the right advice. And this is a picture of a hand of a child with dactylitis whose parents chose to use cold compresses, ice packs, to treat the pain, which is kind of not unreasonable if you don't have any information, which resulted in kind of obviously reduced blood flow and infarction and loss of the fingers. Moving on to acute chest syndrome, which is the second commonest reason people come into hospital. It's defined really as any sort of new pulmonary infiltrate involving at least one complete lung segment. And typically you have other features with chest pain, high temperature, wheezing, or cough. In practice, it means that if you have sickle cell disease, you can't really be diagnosed with pneumonia or simple pneumonia, in the sense that everyone has to have acute chest syndrome if you've got consolidation. And that's probably a reasonable thing, in that you can't really have infection without also getting vaso-occlusion in the lung. This is the typical chest X-ray appearance in a child with bilateral kind of shadowing. And this is the pathology, which is a kind of, you develop a vicious circle in that the hypoxia causes vaso-occlusion in the lung, which causes more hypoxia, and you potentially set up this destructive cycle, which results in rapid loss of lung tissue. Infection is an important component. In studies in the States, because people are all have prophylaxis against pneumococcal, then in fact atypical organisms, chlamydia, pneumonia, mycoplasma, and viruses were more common. At the moment, obviously everyone's very focused on COVID-19, and we've seen in the UK we've seen a lot of people with sickle cell disease come in with COVID-19. In general, it's not very clear whether they do worse or better than people with sickle, but without sickle rather. But there's certainly been about 200 people that we've got data on, and it's not clear. They don't seem to do a lot worse than those people without sickle. They still, obviously some still die, but then that applies to the general population. I think we're concerned that sickle people may be much more vulnerable to COVID-19, and they're recommended to shield. It's recommended that they stay inside. But in adults, adults there's possibly been a slight increased mortality compared to matched populations. In children, there's been very, very little pathology related to COVID-19 so far. There are other pathological mechanisms taking place in acute chest syndrome, including hemolysis and inflammation. The symptoms are typically involve fever and cough, and the outcome tends to be fairly good in children and worse in teenagers and adults. Typically, people are in hospital for 10 days. A small number, 10% of adults, require mechanical ventilation, and about 3% die. Again, in pediatric population, the death rate is less. Stroke is the other important complication I'll just quickly whip through. Stroke, it used to be the commonest, sickle used to be the commonest cause of overt stroke in children, but that's changed with primary prevention based on transcranial Doppler programs. Without prevention, about 11% of young adults have had an overt stroke, and that goes up to more than 20% by the time you're in your 40s. Primary prevention has been largely successful in reducing the incidence of stroke by about 90%. And stroke now is relatively uncommon in pediatric populations, although still occurs in adult populations. The pathology is primarily block damage to large blood vessels, typically the middle cerebral artery. It's not entirely clear why that happens, other than it's part of a vasculopathy, but it's not vaso-occlusion of small blood vessels. And this is a typical X-ray appearance of someone who's had a stroke. This is at the bottom. I don't know if you can see the pointer, but the middle cerebral artery is occluded, corresponding to the area of infarct on the top figure. This is the incidence of stroke in California since the onset of transcranial Doppler screening, showing a significant fall from the 90s. And again, we've seen that across the world. In any country that's been able to implement transcranial Doppler screening with blood transfusion, then the incidence of stroke has fallen. The other aspect of stroke is so-called silent infarcts, where there's no overt clinical event corresponding to the stroke, but on MRI scanning you can see small areas of infarct, and these are shown here. These little dots with the arrows pointing to them. Although they don't cause overt clinical symptoms, they are associated with significant problems, including a higher risk of going on to develop an overt stroke and poor academic attainment. So it's been rushed through quite a few complications, but in summary, sickle cell disease is one of the commonest severe genetic diseases in the world, and it provides a very significant, in any country where it's at all common, which would include Saudi Arabia, then it produces a significant burden on the individual and healthcare systems. The pattern is changing in general, in that there is increased survival of older patients with multi-system diseases. Acute complications are mainly pain and acute chest syndrome, and chronic complications are mainly chronic pain and progressive organ damage. Thank you. That's the end. What do I do now?
Yeah, thank you, Prof. Rees, for keeping on time. Excellent and elegant talk. We'll keep the questions to the end. So we'll move to our next speaker, Professor Wasil Justiniya. Prof. Justiniya, he's well known to our community, hematologist. Dr. Wasil, he's the a consultant of pediatric hematology, and he's the chairman of Princess Noor Oncology Center, King Abdulaziz Medical City, Western Region, National Guard Health Affairs. Dr. Justiniya will be talking about what beyond sickling and sickle cell disease. Again, to remind you, at the end, we'll have room for questions and a survey. Yes, please, Dr. Justiniya, you can go ahead.
Thank you very much, Dr. Ahmed. It's my pleasure really to be with you today. And I'd like to thank the Saudi Society for Blood and Marrow Transplant for giving me this opportunity, and Novartis for sponsoring this event. So the title that I was asked to present is really to answer the question of what's beyond sickling and sickle cell disease. And I thought to do that, the best, let me see if I can work this appropriately.
There's a little arrow at the bottom that you can click on, I think. Well, it says 1 to 20, and you press on the...
Yeah.
Okay, yeah, there you go. Got it. Got it. Thank you, Professor. So I thought to do this is to first, before talking on what's beyond sickling, I think I'm going to highlight on sickling itself and hemoglobin S polymerization as a initiating event. And then I will focus on what's beyond. And to focus on what's beyond, I'm going to highlight three main pathways that have been the focus of new novel drugs that have been recently approved, mainly the adhesion-mediated vasoocclusion, hemolysis-mediated endothelial dysfunction, and inflammation or sterile inflammation. So sickling is really the initiating event. And as you may all know, sickle cell disease is an autosomal recessive disorder where two parents need to be carriers, or one of them diseased and one carrier, to produce a child with sickle cell disease. And the hemoglobin S gene really results from a single nucleic acid base change from alanine to thymine that changes the code of the amino acid from a glutamine to valine in the beta globin chain. And this change in amino acid causes a biochemical change in the hemoglobin molecule, particularly in the deoxygenated state, where molecules become hydrophobic and formulate this lock and key effect in the deoxygenated state, causing polymerization. And these polymers precipitate in the red blood cell, causing the red cell membrane damage and the change of the sickle cell to its sickle cell shape. So this red cell membrane damage as a result of the polymerization the red cell membrane damage as a result of the polymerization causes cation loss due to leaky membranes causing red cell dehydration. But also this membrane stretching or damage causes expression of phospholipids that stimulate not only the inflammatory system, but also the coagulation system. Also, the membrane damage causes increased expression of vascular adhesion molecules and also reduces the lifespan of the red blood cell. As a matter of fact, the lifespan of a sickle red blood cell ranges from 10 to 20 days compared to a normal red blood cell of 120 days, so causing a state of chronic hemolysis. So it really starts with polymerization and sickling that causes membrane damage. And beyond this sickling, two main pathophysiological pathways occur. One is the increased adhesion, and the second is the increased hemolysis that initiate a cascade of downstream events that I'll be highlighting. So I'll start by talking about the increased adhesion in sickle cell disease. And with the increased expression of vascular adhesion molecules and the increased selectins and cellular adhesion molecules that occur in sickle cell disease as a result of sickling, we can see that we have multicellular adhesion, not only of red blood cells, but also of white blood cells, platelets, and endothelial cells. And we know this from earlier preclinical studies on mouse models. And this is one study that hopefully will pop up soon. So this is one study on mouse models that looked at sickle cell mice that were deficient in both P and E selectin. And these sickle cell mice that were deficient in P and E selectin had less leukocyte recruitment to the vessel wall and were found to be protected from vasoocclusion, highlighting the role of leukocytes in the vasoocclusion process as a result of increased selectins. Another model, mouse model, also showed the importance of selectins and increased expression of selectins on the endothelial cells. And in this study, they looked at normal mice and looked at the blood flow velocity in these mice, showing that these mice had a normal flow velocity when compared to sickle cell mice that had a significantly reduced blood flow velocity in terms of millimeters per second. And when these sickle cell mice had a knockout of the P-selectin, genetically modified to have a P-selectin knockout, the flow velocity in these P-selectin knockout mice were similar to controls, again highlighting the role of P-selectin expression on endothelial cells in vasoocclusion. Another study looking at inhibiting P-selectin using a anti-P-selectin molecule in sickle cell mice showed that mice that were given an anti-P-selectin had an 80 to 90% reduced adhesion of erythrocytes and leukocytes to the endothelial cells. And these mice that were treated with, sickle cell mice that were treated with this P-selectin inhibitor had increased flow velocities and reduced leukocyte rolling on the endothelial cell. In addition, these mice had reduced mortality compared with the control mice that were not given this anti-P-selectin inhibitor. So this study concluded that P-selectins promote adhesion of sickle red blood cells and leukocytes to the endothelial cells, highlighting their role in vasoocclusion again. More recently, a complete P-selectin deficient mouse model was developed in this recently published study. And they compared the SS mouse to the P-selectin deficient mouse. And as you can see, the SS mouse had a increased expression of P-selectin compared to the knockout mice. And when they looked at the liver sections of these P-selectin deficient mice, they found that SS mice had a increase in sinusoidal congestion in this section as seen here, and increased collagen deposition indicating liver injury and liver fibrosis compared to the complete p-selectin deficient mice, where there's less pink staining on the liver sections on both the top and the lower figure seen here. When they looked at lung tissue, again, they found that the SS mice had increased red dots and green dots, indicating increased leukocyte obstruction and platelet adhesion in the lung tissue of SS mice, which was significantly less in the p-selectin deficient mice. So collectively, the study showed that p-selectin deficient mice are... Can you see my slides?
No, it's disappeared. Oh, it's back.
Yeah. So collectively, this study showed that p-selectin deficient mice are protected from lung vaso-occlusion and liver injury. So these studies collectively indicate that sickling increases expression of vascular adhesion molecules and selectins, leading to multicellular adhesion, which is a major contributor to the pathophysiology of vaso-occlusion in sickle cell disease. So the other pathophysiological pathway that I will highlight is the role of hemolysis. And when red blood cells hemolyze, they release the contents of these cells. So hemoglobin is released, and the arginase, which is one of the components of the red blood cell, is also released. The release of arginase converts L-arginine to ornithine, and L-arginine is a substrate for nitric oxide. So the arginase converting the L-arginine to ornithine will lead to a reduction of the nitric oxide. In addition, nitric oxide chelates or reduces the oxidative stress of free hemoglobin, leading to all nitric oxide being scavenged by the free hemoglobin to convert it to methemoglobin to reduce the toxic effects of the free hemoglobin. As a net result, nitric oxide has a significantly decreased bioavailability from the chronic hemolysis. And this decreased nitric oxide availability leads to endothelial dysfunction, endothelin and endothelial receptor upregulation, and proliferative vasculopathy. So you have a hemolysis endothelial dysfunction vasculopathy pathway as a result of the reduced nitric oxide in patients with sickle cell disease and chronic hemolysis. So the other important pathway is the inflammatory pathway, or the sterile inflammation. And inflammation in sickle cell is really an end product of both vaso-occlusion and the chronic hemolysis. So vaso-occlusion causes this ischemia reperfusion injury, which increases the release of cytokines, and hemolysis through the toxic effects of heme stimulate the inflammatory pathway through the toll-like receptor 4 pathway, which increases both multiple adhesive molecules, including p-selectin, e-selectin, different cellular adhesion molecules, in addition to cytokines and coagulation factors. So leading to a pro-adhesive and pro-coagulant phenotype in sickle cell disease. And really, inflammation happens as a result of sickling. And there are multiple inflammatory pathways that lead to this sterile inflammation. So one that we showed earlier, which is the multicellular adhesion molecules that are overexpressed, leading to adhesion of inflammatory cells, not only red blood cells. The increase in the reactive oxidant species as a result of the oxidant stress, and the redox inflammatory pathways that happen as a result of this. Activation of the innate immune system, whether it's activation of complement toll-like receptors or the inflammasome that is increased in sickle cell as a result of the sickling and the hemolysis, in addition to activation of neutrophils that have been described in patients with sickle cell disease. So really, patients with sickle cell disease have a state of pro-inflammatory and pro-oxidative milieu or environment that results in this chronic state of inflammation. So inflammation activates or increases the expression of multicellular adhesion molecules, which increases the vasoocclusion. The vasoocclusion causes tissue and organ damage, which releases cytokines and increases the inflammation, setting this vicious cycle that continues to cause the pathophysiology and clinical manifestation that Professor David showed earlier. And this is a nice figure that was actually published by Professor David, which shows the combined complex interacting pathophysiological mechanisms, starting from the first event, which is the polymerization and sickling that leads to the vasoocclusion. And this vasoocclusion leads to the ischemia and inflammation, and also the hemolysis leads to the end result of the inflammation, which is a two-way kind of pathway. The inflammation aggravates the vasoocclusion, which again sets this motion of a vicious cycle. And the hemolysis leads to the reduction of nitric oxide bioavailability. And cumulatively, the vasoocclusion, reperfusion, and the hemolysis leads to the end result of vasculopathy and endothelial dysfunction. So really, sickle cell pathophysiology is a vicious cycle that starts with sickling, but beyond sickling, different pathophysiological pathways happen that lead to the multiple phenotypes and multiple end organ damages that we see in patients with sickle cell disease. And these main pathways are the hemolysis, vascular occlusion, and the systemic inflammation that happens in patients with sickle cell disease. So to answer the question of what's beyond sickling in sickle cell disease, I thought that I can come up with my own definition of how to define sickle cell disease today. So sickle cell disease can be defined as a chronic inflammatory disease that is a result of complex interacting pathological pathways that are downstream of one another, starting with a point mutation in a DNA that leads to polymerization and red blood cell membrane damage that leads to chronic hemolysis, anemia, multicellular adhesion and vasoocclusion, ischemia and reperfusion leading to inflammation, hypercoagulability, and proliferative vasculopathy. Collectively, these lead to progressive multi-system clinical manifestations that can be subclinical or silent for a period of time, or present as pain and acute intermittent crisis, cumulatively leading to organ damage and a reduced lifespan for patients with sickle cell disease. So our understanding of disease pathophysiology in sickle cell disease has advanced, and this has allowed for targeted approaches to prevention and management, which is now possible, and has paved the way for new drug developments that are now being approved and being used in the clinical setting or in clinical trials in patients with sickle cell disease. Thank you very much.
Thank you, Wasil. This is excellent. So we'll open the webinar for questions. Let me see how we handle this. Great talks. Let's see. Yeah, so until we receive the questions, so there's a Q&A here, so please post your questions. let me see where is our survey here. Okay, so can we get the people to answer these this vote, please? So it's timed. So go ahead and put your specialty. Okay. All right, so we're still getting questions. More people to fill out these this survey, please. Okay, we've got almost half. All right, thank you. Yeah, we've got actually almost more than half of the attendees who are exceeding 300, about 300. Yeah, exceeding 300. About more than half are between adult hematology, pediatric hematology, and hematopathology. Yeah, thank you. Again, so we'll go to the questions. We've got, so what is the role of RBCs, apheresis, and controlling the VOCs? So, all right, our speakers. So what's the role of RBC apheresis in controlling the VOC? Dr. Rees, you could.
Yeah, well, there's not a lot of evidence to say, well, there are no big studies showing that it works, other than there's an incidental finding in things like the STOP study where patients were transfused and it was shown that the episodes of pain decreased. I mean, our practice is to, obviously try and use hydroxyurea, and that works well in the majority of people. And there's a small number of people who continue to have frequent problems despite hydroxyurea. And then those we then discuss putting them on regular blood transfusions, and that can either be top up or, more commonly now in adults, then exchange transfusions. So for us, it's kind of third choice after hydroxyurea. But it does, in some people it works remarkably well. Others obviously have quite more complicated problems to do with chronic damage to organs, and you reduce the amount of sickle in the blood doesn't have a big impact. But we do use it. Quite increasing numbers, particularly in older adults. As I said, there are a lot of old adults now with multi-organ problems, and often apheresis then is it seems to be one way of managing the problems.
Right. Wasser, what's your practice with the apheresis?
Yeah.
How common, frequent?
Yeah, so if the question, so vaso-occlusive crisis, what most refer to vaso-occlusive crisis as meaning pain crisis. So for pain crisis in general, transfusion or apheresis is not a standard treatment approach. So it's or a recommended approach. So for most uncomplicated, straightforward pain crisis, we don't use the blood transfusion or apheresis in these kind of patients. Now, if the meaning is vaso-occlusive crisis as acute chest syndrome, as a broader term of vaso-occlusive crisis, then yes, blood transfusion, apheresis, or depending on the severity of the case and the baseline hemoglobin level of presentation, is a approach that is used. So I hope that helps the question.
Great. All right, Dr. Rees, you commented on the increasing age for sicklers in certain countries. What do you attribute that to? I mean, do stem cell transplant has a role in this, or is it just the hydroxyurea and other measures?
It's not stem cell transplant, certainly, because so relatively few have been done, even in the most transplant-happy countries. I mean, I think you're right. I mean, hydroxyurea is part of it, but I think it's probably general. Everyone's life is, life expectancy is improving in high-income countries for everyone, and I think it's more general medical care that people have better vaccinations, they take penicillin, and there are more specialists and there's better hospital facilities. So I think certainly so far, there's not been one medical intervention that has improved it. As I said, the improvement in life expectancy really started before there were any treatments at all. It was more, just providing basic medical care. And a lot of sickle management isn't, there aren't a lot of drugs at the moment to choose from, but it's about providing, good medical care and good supportive care. So I think it's mainly to do with that.
Right. Okay, I have a question here. Yeah, how about penicillin in adult sicklers? What is their role?
Well, we give it in the UK, and Europe. It's generally, although in the States they stop at the age of 5, we continue it into adulthood, unto death. Although quite a lot of people stop taking it, but we think there's probably no side effects as such, and there may be some small benefit.
Right. There's a question about the analgesics and overuse. So what's the best way to deal with these people? I know it's this would be a long. I mean, if you could find us a short answer to this.
Good clinical management is the answer.
Yeah.
But that's easy to say and very hard to do.
Yes, I know. Would you consider those for a stem cell transplant, those who are addicts? So in order to, would you consider it as an indication?
I think it probably is an indication. And again, depending on where you live and what the resources are.
Yeah.
I think in a serious answer to the question, I think we feel that trying to avoid intravenous treatment in childhood is possibly helping, and that say where I work at King's, we used to have a very big population of adults. There used to be 30 patients who came in every day with basically problems with analgesic use, and we've pretty much got rid of those by a lot of support. It's been very expensive and a lot of psychological support, and far fewer children are developing that pattern, because now, as I said, we try and manage all episodes of pain with all analgesia, with all opiates, and we'd never send children home on opiates. And I think, I think it is, it is a iatrogenic problem, and it's not intrinsic to the disease. And also, if you didn't have opiates, it wouldn't happen. So it's a question of trying to manage people in a humane way, i.e. not leaving them in loads of pain, but also not creating a problem as well. It's a difficult balance.
Yeah, maybe Prof. Rees, if you can mention how common do you see addiction in sickle cell? Is it a problem, really?
Well, addiction is not a word we tend to use. I mean, I think there are a very small number of patients who are genuine addicts, in the sense that they, their whole life revolves around trying to get drugs, and they use sickle cell as a way of getting analgesic. And that, I think, is quite uncommon. But in the same way there are addicts everywhere, there are some people who are addicts and also have sickle cell disease. And there's a much bigger population of people with chronic pain who require chronic opiate analgesia and spend a lot of time coming in and out of hospital. And I think the answer is to you try and develop other ways of managing the pain. And psychology support and pain specialists are helpful, definitely, but they're not very widely available, and it is very time-consuming and very expensive. To get one patient in a better position on less analgesics. It takes a huge amount of time. So when you have, I guess, as in Saudi and in the UK, when you have huge numbers of patients, there aren't the number of psychologists needed to do it.
Correct. Yeah.
But I think we don't like using the term addiction, except for a very few patients. It's a iatrogenic problem. These people have been treated. We don't have a specific treatment for acute pain, so we give them loads of opiates, and then they require, they stay on opiates. Right. The thing in the UK that made the biggest difference in terms of patients with drug problems was switching from stopping using pethidine. People used to use pethidine and it caused huge problems, and now using Oromorph and morphine has reduced the number of patients in hospital by about 50%. I don't suppose you use pethidine, but I think good, sensible analgesic stewardship is useful.
Yeah. So another question here. For our attendees, we'll try to actually select some of these questions. I don't think we'll be able to have lots of questions, and I don't think we'll be able to cover it all. However, we'll screen through and select something that's not overlapping. So what would be your recommendation for patients with silent brain impacts? So we could hear from both. Dr. Rees?
Firstly, we don't routinely screen. I mean, we are thinking of doing MRIs on everyone from the age of 7. So we only pick them up if we think there's a clinical problem. And then we discuss it with the parents, and we discuss the evidence that blood transfusions can be helpful in terms of reducing the incidence of further silent infarcts. In practice, we transfuse very few people for silent infarcts, and we see it as another indication for hydroxyurea. So,
right.
There was a big study, the SIT study, showing benefit from transfusion, but I think most of Europe certainly hasn't really adopted that as practice.
Yeah. Wasil?
Yeah, so we, although there's no strong recommendation to screen for silent infarct, again, we use a similar approach. We screen our children when they're able to go to the MRI without sedation. So around 7, 8, 9 years, we do an MRI, MRA to look for silent infarcts. And if they have a silent infarct, we actually counsel our patients between transfusion and hydroxyurea, telling them the pros and cons of both approaches. I can say that majority, when we do the counseling, choose the transfusion, but we have some that prefer to go with the hydroxyurea. And we monitor these patients once every 1 or 2 years with MRIs to see if there's progression with one management versus the other, and take it from there. But again, these patients are one of those patients that are an indication for transplant if they progress or show some decline in their school performance in general, if you had access to psychoeducational testing. So we use this as a early screen to prevent long-term progression, basically, as a first event that happened to a patient.
Right. Okay. A question for Dr. Wasil here. Let me see, publish that here. Okay. So what's the role of thromboembolic phenomena and immune dysregulation in the pathophysiology of sickle cell? I think
so there are two. Maybe the one that I didn't cover very much is the thromboembolic phenomena. Yes, sickle cell disease is a hypercoagulable disease, and there are different additional risk factors that may increase the risk of venous thromboembolism in these patients. And I think there was a recent study that was published, I think, just a couple of days ago in Blood Advances that looked at different risk factors for thromboembolism, both arterial versus venous. And I would refer you to that paper to look at. It's an interesting paper that looked at different risk factors that were significant, which included age. Interestingly, use of hydroxyurea increased the odds of having venous thromboembolism, and I think that's because patients were doing well and living longer, so they had more events. Yes, it is a hypercoagulable state, but there's no evidence that so far that prophylaxis against thromboembolism is a standard of care in these patients, although some of the newer medications that are coming out are testing reducing events and reducing disease-modifying, using it as a disease-modifying therapy, are drugs that inhibit the coagulation system as well. So it is a big topic, and I think we have more to learn about venous thromboembolism and sickle cell disease and the best approach for these patients.
Right. And one last question here before we conclude. So would you recommend any thromboprophylaxis in pregnant women? And the question says here for sicklers and for sickle cell trait.
Okay, so I don't deal with pregnant women, but again, the standard approach is you would do what you would do in a non-sickle cell patient. So if you would prophylax in a non-sickle cell patient for whatever indication that pregnant female, whether it's hospitalization or others, then you would do the same approach. There's no added, to my knowledge, no added evidence that you should approach a pregnant sickle cell patient differently from the thromboprophylaxis perspective. Now, importantly, contraindications to anticoagulation needs to be kept in mind, particularly that this adult age group has a high risk of hemorrhagic stroke or having CNS vasculopathy. So you have to keep that in the back of your mind, the indications and the contraindications of anticoagulation in the older age group. I don't know if Professor Rees has any comment here.
Not really. Like you, I see mostly children, but in the UK, all pregnant women are put on aspirin, not so much for anticoagulation. All pregnant women with sickle, because of the high incidence of preeclampsia, and that there's not a lot of evidence to support it, but that is the standard guidelines. Other than that, it's kind of, as you said, really. I think everyone's individually assessed for their thromboembolic risk score, and sickle is a factor in that score, but it's not in itself an indication for anticoagulation. Sickle cell trait, although there is a increased VTE risk, it's not treated differently.
Yeah, great. I think we will have to conclude. Now the time is over. And I would like to thank again our two professors, David Rees and Wasel Justania. And thank you, our attendees, again, for being with us till the end of this session. And thank you, Novartis, for sponsoring this event. And again, to remind you of our next webinar will be on the 16th. Again, it's a sickle cell, so it's like a second webinar related to the same talk or same topic. And we will have two, again, good topics to cover: the innovative treatment for sickle cell disease and the sickle cell disease and BMT. So I did not cover those questions that related to new therapy and BMT, because we will have a session on the 16th that covers these two talks. Again, thank you, everybody, and have a wonderful night. Thanks.
Thank you.
Thank you.
Bye.